All right, guys, we're on chapter 22, nursing care of patients with hypertension. This one's going to be a little faster. We only have 31 slides, so stay with me. All right, our learning outcomes. We want to explain the pathophysiology of hypertension, identify causes and risk factors for hypertension, list signs and symptoms of hypertension, describe therapeutic measures for hypertension, define classifications and treatment recommendations for hypertension. Define hypertensive emergency, list common complications of hypertension, plan nursing care of patients with hypertension, and evaluate the effectiveness of nursing interventions. All right, so blood pressure. Hypertension is a risk factor for cardiovascular disease risks and stroke. Hypertension prevalence is high. Normal blood pressure is less than 120 systolic and 8/80 diastolic millimeters of mercury. Hypertension screening for those with normal blood pressure every 3 to 5 years is appropriate. For those over the age of 39 or with increased risk, they need to be checked annually. Pressure exerted by blood on the walls of the blood vessels is determined by cardiac output, peripheral vascular resistance, vessel stretch, and blood viscosity and blood volume. So let's go over this real quick. If our body is demanding more blood, maybe because the patient is overweight, maybe because, you know, for various reasons, our blood pressure is going to be higher. Some people have type 1 personalities where they have anxiety when things don't go exactly how they want to go. These people tend to have hypertension because of the own stress caused by their own tendency to demand things a certain way. Um, so cardiac output is basically is your body under stress. Primary hypertension is of unknown cause. We don't have any reason for it. Secondary hypertension is it's caused from something else. So if you have atherosclerosis, if you have any other cardiac disease, hypertension is pretty much an expected finding. If you have heart um, failure, likely it's from hypertension, but it's hard to say. I mean, is it because is it the chicken or the egg? Did the heart failure come from hypertension or did hypertension come from the heart failure? Likely you've had long-term hypertension and it's overworked the heart, and that's how the heart failure occurred. So hypertension signs and symptoms, there's really none, right? I mean, it's considered the silent killer. But rare signs and symptoms, especially if you have an intense increase suddenly, can cause headache, a bloody nose, anxiety, and dyspnea. This typically happens when a patient is on blood pressure medication and they stop taking it abruptly. Their body will revolt and go back to hypertension, and their body's been used to not having hypertension for a long time, and then suddenly it jumps up to 200 over 100 and the body did not adjust to that. But people who suffer from hypertension for a long time, their bodies adjust, and until they get put on antihypertensive medication, their body will then adjust to the lower blood pressure and they will have signs and symptoms when suddenly they stop taking that medication. Another reason is if they go into a hypertensive crisis, like say they went under a huge amount of stress. Uh, I always make fun of my husband because he would get mad at our kids, and I could see his jugular vein distend. And he's like, I got a headache. I said, well, you need to sit down because you're going to end up busting a blood vessel and having a stroke because your blood pressure is probably through the roof right now. Well, that would be a hypertensive crisis situation. I mean, that is somebody who already has blood pressure and something stressed them out so much that they increase to a higher level where they're having signs and symptoms. That's pretty bad. But risk factors for hypertension are usually overweight, older, 40s, 50s, high stress jobs, poor eating habits, large salt intakes. Um, what else? It's genetic as well. African American, Hispanic American are a higher risk for hypertension, kidney or heart disease. Current medications can also, increase your chances for hypertension sometimes. So we want to get an ambulatory blood pressure monitoring device to test and see, because typically when you check somebody's blood pressure, they're sitting down, they're relaxed, they haven't done any exercise. That really isn't an accurate reading. We're not all sitting around all day. So if they're borderline by just sitting down, you can imagine on a typical day their blood pressure gets higher when they're in activity or doing things, right? Modifiable changes are things like diet, um, weight loss, not smoking, things that you can actually change. So non-modifiable risk factors are family history of hypertension, age, race, and ethnicity. Modifiable risk factors, again, are increased physical activity and glucose control. Hypertension treatment, first they start off with a diuretic, because that is the least invasive with the least amount of side effects. You're going to be peeing a lot, but no big deal. Let's see if we can lower your blood pressure by taking away some of the fluid volume, right? If that doesn't work, we're going to go to ACE inhibitors. Now, we wouldn't give ACE inhibitors to African Americans because that can cause endocarditis and basically rupture valves in the heart. So we want to not do that. But the next step would be angiotensin receptors blockers, which is your beta blockers. And then our last step would be a calcium channel blocker, because both of those have a lot of side effects that can cause orthostatic hypotension and other side effects that aren't attractive. So they want to do the least invasive to the most invasive. Now, diuretics, ACE inhibitors, calcium channel blockers, alpha blockers, and beta blockers. So here we go. There's the classes of hypertension. We got central agents, which work directly on the heart muscle. Peripheral agents, which work on the vessels by dilating the vessels. We decrease the blood pressure. Then there's also vasodilators, like what I was talking about, and aspirin. 100 milligrams at bedtime will lubricate the blood so that it goes through the system easier. And that also may slightly decrease the workload of the heart, decreasing hypertension. So complications of hypertension are atherosclerosis, meaning hardening of our peripheral arteries, coronary artery disease as well, myocardial infarction. By the way, coronary artery disease is the advancement of atherosclerosis. An MI is a blood clot blocking the coronary arteries, heart failure, stroke, and kidney and eye damage. Severe blood pressure elevation without target organ dysfunction progression. So hypertensive urgency, this is severe headaches, nosebleeds, shortness of breath, and severe anxiety. Treatment needs to be implemented quickly because it can lead to stroke or an MI. A hypertensive emergency is a systolic blood pressure higher than 180 or a diastolic higher than 120. Risk for a progression of target organ and dysfunction. Immediate gradual reduction of the blood pressure to target organs. Your treatment is going to be nitroprusside, which is going to decrease the blood pressure quickly. It's really recommended that this patient is on an telemonitor. Our nursing diagnosis for readiness for enhanced health literacy, ineffective health management, and risk for unstable blood pressure. Patient education, lifelong BP control. This is forever. That's the only problem with blood pressure. It's not like anything you do is going to cure it. You might lose a bunch of weight, and it may better your prognosis, meaning you might be on less medication, but chances of it eliminating completely are far to none likely. Self-care lifestyle measures and prescribed medical regimen are going to be part of um, your life, and you can't take, you're pretty much going to be dependent on them. So teaching, dizziness may increase the risk of falling, and you will have dizziness because a lot of these medications cause orthostatic hypotension. So you want to teach the patient to rise slowly to prevent this problem, especially with beta blockers and calcium channel blockers. Excuse me. What is the cause of primary hypertension? Kidney disease, adrenal gland tumor, heart failure, or unknown cause? The answer is 4. We don't know why primary hypertension occurs. The nurse would include which of these as modifiable risk factors in the patient teaching plan. Select all that apply. These things are things we can do. Diet, glucose control, and weight control. So 2, 4, and 5. The nurse is contributing to the plan of care for a patient with a new onset hypertension who has requested information to manage the hypertension. Which of these nursing diagnoses is appropriate? 1, increased cardiac output. 2, ineffective health management. 3, ineffective coping. Or 4, ready for enhanced health literacy. I would say number 4 is your answer. The nurse evaluates the patient as understanding teaching if the patient states hypertension must be managed for which time frame. Uh, Remember I said it's lifelong. It doesn't just go away. So the answer is 4. What should the nurse include in the patient's teaching plan to prevent falls when taking antihypertensive medications? Select all that apply. So sit at the bed when changing positions. Yeah, you want to dangle, remember, because your blood flow is a little bit slow to the brain. We need to rise slowly, so 1 and 2. If dizzy, sit down. 3. Stand up quickly. No. Request assistance to stand if you have a history of falls. Yes. 1, 2, 3, and 5. All right.